Thank you very much. I want to thank the organizers, Dr. O in particular, who's been a dear friend and colleague over the years and has organized just what I believe to be a world-class symposium here. And I look forward to the continued success of this meeting. So my challenge today is to talk a little bit and provide some context about the role of radiation in this new era of immunotherapy, and try to move the position of radiation beyond just a tool to deliver local control. And so I thought I might start with a bit of historical context. I like this quote that is attributed to Dr. Burwell, who is the Dean of Harvard Medical School from 1935 to 1949. And he said, "Half of what we're going to teach you in medical school is wrong, and half of it is right. Our problem is that we don't know which half is which." And this is very true if you think about the era that we are currently in. The paradigms that we held true just a few short years ago have now started to be turned over. And we view patients very differently, particularly in lung cancer. I think this era right now is one of unprecedented optimism in terms of the management of lung cancer, which just a few short years ago was probably a disease that suffered the most from what has come to be termed therapeutic nihilism, which is a feeling that this is such a devastating disease that patients, should really just be routed for palliative care, and the chance of cure is so hopeless in this disease. Why are we flogging patients, and why are we putting them through side effects when they're not likely to benefit? So here are some truisms that I have encountered in just the course of my career about lung cancer and metastatic disease. One of the statements that was made by the chair of surgery at that time at the Sloan Kettering Cancer Center in a seminar that I attended in 2002, 2003, said that there was absolutely no more hopeless diagnosis than metastatic melanoma or lung cancer that has spread to the brain. And this, of course, is our former president, Jimmy Carter, on the date of his diagnosis announcing to the world that he has been diagnosed with melanoma that has spread to not only the liver but also the brain. The date of this announcement was August 20th, 2015. And if you look at him here today, this is a very recent photograph from just earlier this year, June of 2017. So the feeling was at that time, with the spread of melanoma to the brain, your survival just does not make it past 6 months. And if you look at the survival curve just a few years ago, this was true. You had to question the diagnosis if you had a patient with metastatic melanoma to the brain who survived beyond the 6-month time point. And this is President Carter alive 2 years plus, and he's still continuing to thrive and be very active. And this is partially attributable to the magic of immunotherapy, and we'll talk more about that. If a patient is diagnosed with stage 4 non-small cell lung cancer, the bottom line is all treatment is palliative. And this was said to me during my training at Sloan Kettering by a lung cancer expert and a board examiner. And these are data here that everybody in the room should be familiar with. This trial isn't that long ago. This was the state of the art in stage 4 non-small cell lung cancer. Joan Schiller's trial published in 2002, looking at 4 platinum-based doublets and long-term survival in stage 4 disease. And the median survival was 10 months, regardless of the therapeutic regimen that was employed. And just in the succeeding 9 years, we've marched that survival up from 10 months to 12 months to 24 months and beyond in certain subsets of patients with mutation-positive disease. So now we're looking at survival numbers that are so different from what we were encountering just a decade ago. And as the previous speaker, Dr. Yang, I really appreciate a surgeon who speaks highly of SBRT. Can I tell you, as a radiation oncologist, this was very heartwarming to me. But this was something that I've heard many, many times. Surgery is the only curative modality for lung cancer, because lung cancer, particularly non-small cell lung cancer, is a radio-resistant tumor. We know that biological models predict that you need to deliver doses over 100 gray, and this is just not feasible to do safely. And of course, we now have more and more emerging randomized data to suggest that using approaches such as SBRT, you can provide a reasonable alternative to surgery in the setting of early stage disease. So, what facts do remain today in 2017? The fact of the matter is the primary cause of death for patients with advanced solid tumors still remains metastatic progression of disease. And in recent years, we've started to tease out subset of patients who have so-called oligometastatic disease or oligoprogressive disease in whom local control, either with surgery or radiation, can actually prolong progression-free survival and improve clinical outcome. But what do you do? This is a very specialized subset of patients, the ones with oligometastatic disease. What do you do about the 80 to 90% of patients in whom you have fulminant progression of distant metastatic disease? How do we improve outcomes in these patients? This is why cancer immunotherapy has provided unparalleled promise and optimism, because it addresses this very subset of patients. The challenge with a patient with systemic metastatic disease is the tumor is inseparable from normal tissue. And so our general approach in oncology is to intensify treatment, and by intensifying treatment, we're able to affect greater tumor cell kill. The problem is when the normal tissue is tightly connected to the tumor, virtually inseparable from the tumor, which is the case in systemic metastatic disease, treatment intensification doesn't work so well. We need some sort of selective systemic therapy. And in the absence of a biological target, which most solid tumors we still don't have druggable targets for, the best weapon we have is our immune system. And that's the reason why cancer immunotherapy has provided such a boon to patients with systemic metastatic disease. So the era of systemic immunotherapy really was heralded by this trial, which was in melanoma. It was a HODI study, which was published not that long ago, 2010. And it was looking at patients with pre-treated metastatic melanoma, treatment resistant. These patients had all failed at least one prior line of therapy, and they were randomized to either a tumor vaccine or to ipilimumab, which you all know is a checkpoint inhibitor that addresses CTLA-4. And what was seen for the first time in the history of the management of metastatic melanoma was a survival benefit. This had never been seen before. You had a survival benefit with patients with metastatic disease, 20% of them living out past the 4 or 5 year time point. So that was a huge victory. Prior to that, any treatment that you may have employed in metastatic melanoma may have delayed progression but did not improve survival. So what was particularly important about this study is, remember, for the first time we were using a treatment that does not attack the tumor. All it does is tweak the immune system, specifically the T lymphocytes a little bit, and now you have a survival benefit. So you're using a treatment that is not tumor-directed, and you're now achieving a survival benefit. So this was a big, big, big study, and it was a landmark trial that kind of ushered in this era of immunotherapy. But there were some challenges that were apparent from this early study and from other studies similar to this, which is that the majority of patients who are given immunotherapy, even today, fail to respond to the treatment regimen. So when you look at response rates, and this was discussed yesterday, the response rates, depending on the disease, range from 11% in some studies up to maybe 40 to 50% in the most optimistic studies with the best results. And so why is it that the majority of patients fail to respond to immunotherapy? Well, one driving hypothesis to explain this is that perhaps tumor antigen presentation has failed to occur. So I'll describe a little bit more what I mean by this as we go forward when we talk about immunotherapy. So could radiation potentially facilitate tumor neoantigen release? That's the question that I'm going to try to address here. So this is an example of a patient with metastatic adenocarcinoma of the lung with just 3 sites of disease, was not receiving any systemic therapy whatsoever, was referred for SBRT to this lung lesion and received it. 26 gray, had a good response, what you would expect with high-dose locally ablative therapy to a right lung primary. But what was unexpected was this. The liver met as well as the humoral head met also dissolved away. And this is in the absence of any systemic therapy whatsoever. So what happened here? Why did this occur? This is an example of the so-called abscopal or off-target effect, which is not too often seen, but when it is, it's very impressive in the setting of radiation treatment of a patient with metastatic disease. So the thought is, what happens is that when you deliver high-dose focal radiation, you facilitate release of tumor neoantigens. And we spent a lot of time yesterday talking about the importance of neoantigen delivery and neoantigen payload in order to facilitate checkpoint inhibition efficacy. So with radiation, you, in a sense, create an in situ tumor vaccine using the tumor itself through the release of these neoantigens, which are then picked up by antigen-presenting cells, and then you get clonal expansion of tumor-specific T cells, and then these T cells can then mobilize into the systemic circulation. So one of the things to remember is that these checkpoint inhibitors that we talk about all operate only at this part of the cascade here. So in other words, you need to first generate the tumor-specific T cells, and then and only then do the checkpoint inhibitors even come into play. In the absence of the presence of tumor-specific T cells, checkpoint inhibitors have no value, because all checkpoint inhibitors do is they prevent the downstream inhibition of these T cells from attacking the tumor. So unless you have the T cells you need in the first place, checkpoint inhibition only provides toxicity without any benefit to the patient. So if this is true, if radiation is so effective at generating an immune response, why is it something that we don't see that often? Well, one question I would ask the group is maybe we're not looking in the right place. So you heard the previous speaker talk about SBRT. And the local control rates that we have seen with SBRT compare pretty favorably with surgery. So can we just attribute this simply to the fact that with SBRT we're doing treatment intensification? Maybe, maybe not. So with SBRT, the kind of control rates that we see are in the 95-98% range, and this is an example of a patient I treated, and delivered a 4-course regimen to this patient, and not surprisingly, had good control, and this patient continues to be controlled today. So is that simply because we delivered a higher dose of radiation, or is there something else going on? This is an interesting experiment from the group at the University of Chicago, but others have duplicated these results. As an example, this is a mouse experiment where they were just trying to look at what impact delivering an SBRT type regimen to a mouse model of tumor does. And this is a syngeneic mouse model of B16 melanoma. And not surprisingly, in a wild type mouse, when you deliver SBRT dosed radiation, you got arresting of tumor growth. That makes sense. That's what you would expect. But they reduplicated this experiment in a nude mouse and see what happened. In the nude mouse, the tumor kept growing despite delivering the same radiation dose. So why is that? So if radiation is just about DNA damage and tumor cell kill, it shouldn't matter whether you deliver the radiation to a wild-type mouse, a nude mouse, or to a petri dish, right? The cell should die off if it's just about DNA damage. However, here, when you put those tumor cells into a nude mouse, they kept growing. And as you know, in a nude mouse, they are incapable of mounting a cellular immune response. That's the distinction between a nude mouse and a wild-type mouse. They went back to the wild-type mouse to try to figure out which subset of immune cells are driving this result, and they depleted the wild-type mouse of CD8 positive T cells, and here's what they saw. They saw the tumor continue to grow again. So if SBRT is simply about treatment intensification and radiation dose intensification, and that's what's driving tumor cell kill, it shouldn't matter whether the mouse has an adequate functioning population of CD8 positive T cells or not. But here we show that it does. So maybe what's going on here is that the SBRT simply lights a fire of generating an immune response, and it's the immune response that's actually the real driver of tumor cell kill. So that's nice data in a mouse. What about in patients? This was published several years ago by Ingrid Grills in the JCO, and she did a case-matched comparison of patients receiving SBRT versus wedge resection at their institution. And what she found was that SBRT had superior local control to wedge, and that's interesting, but it's not terribly surprising. But what is more surprising is that when she looked at regional nodal and distant control, SBRT was superior as well. So the only difference between SBRT and a wedge, either way, you're delivering high-dose intensive treatment to a small focus of disease. Why should SBRT improve regional nodal control? Perhaps what's going on is that you're generating this kind of an immune response that's leading to sterilization of microscopic disease embedded within the regional lymph nodes. So if this is true, if you're willing to believe that maybe radiation is capable of generating this kind of an immune response, if this is really true, how come we don't see this happen all the time, right? In a standard radiation oncology clinic, about half the patients who are being treated have metastatic disease. So if radiation is so darn good at curing these patients by creating an immune response, patients should just be walking out ready to run a marathon every day of the week, right? But we're not seeing that. Why is that? Why are we not seeing that? So a lot of things have to go right in order to generate a systemic immune response if you think about the model. First of all, you need to have a sufficiently immunogenic tumor so that when you release these neoantigens into the system, that you get antigen presentation and expansion of T cells. Second of all, you need to pick the right radiation dose, and we don't know what the right radiation dose is for a given tumor to generate release of these neoantigens. Then you need to have a good, robust immune machinery that can digest the neoantigens and present them to the T cells. And we oftentimes see that you have lack of function of the antigen-presenting cells. And when that happens, no matter how many neoantigens you release, if you lose MHC class I, you're not going to have antigen presentation or clonal expansion of T cells. Furthermore, you need to prevent downstream inhibition by checkpoint blockade, for checkpoint activation. So there are a lot of things that have to go right in order to see this kind of a systemic immune response, but we do see it occasionally, and it's not surprising, in my opinion, that we don't see it all the time. And again, that's because so many things have to go right. Finally, if you think about the way we deliver radiation as radiation oncologists, much of the history of radiation oncology over the last 50 years has been recognition of the so-called importance of treating not only the primary tumor, but the regional lymphatics. Well, there's a problem there. If I'm expanding my radiation field and I'm delivering fractionated radiation to the regional lymphatics, even if I get so lucky as to generate an immune response and get antigen presentation and start creating and expanding tumor-specific T cells, then what am I doing next? When I radiate the regional lymphatics, I'm killing off these very T cells that I worked so hard to generate in the first place. And most standard curative therapeutic regimens in radiation oncology involve treatment of the regional lymphatics and involve prolonged fractionation schemes. So one of the advantages with SBRT is it's a very short fractionation scheme. It's not prolonged. Second of all, it's not a large field. You're not treating the regional lymphatics when you're doing SBRT. So I think there are a couple of things about SBRT that make it a little bit unique and perhaps well positioned to function as a tool in generating an immune response beyond simply the dose. So there are a lot of questions that remain about radiation and immune modulation. First of all, as I mentioned, we don't know the right dose and fractionation or even the right volume that we need to treat. Furthermore, if I have a patient who comes to me in the clinic with metastatic lung cancer and they have a met in the liver, a met in the bone, a met in the lung, I don't know which met is most likely to generate an immune response. Which immune environment is most likely to facilitate antigen presentation? We don't know that yet. Furthermore, we heard talks yesterday about biomarkers. We do not have a biomarker right now, a robust biomarker, to tell us if we're successful. All we can do is follow these patients serially with radiographic imaging, but we don't have any way of simply doing a blood test to say, aha, we've generated an immune response. It'd be great if we could have a TB test for tumor antigen release, but we don't have that. to confirm that we've generated immunity. And then we also don't know what are the drivers amongst the tumor genomic characteristics that make a tumor more favorably predisposed to generating an immune response. So I'll talk about all of these just briefly. So first question is, how do we couple radiation in this era of immune checkpoint inhibition, and what do we do? And these are data from Silvia Formenti that she generated when she was at NYU, and they found that looking at a variety of different dose and fractionation schemes, it turns out that SBRT type regimens, but not single fraction, 2 to 3 to 5 fraction regimens seem to be the best at creating an immune abscopal response with radiation in the setting of checkpoint inhibition. And they were using CTLA-4 blockade here. And so what you can see here, they radiate this tumor and then they follow the response in this tumor, which is outside of the radiation field. And when they used 8 gray times 3 or 6 gray times 5, they got pretty good arresting of tumor cell growth in the contralateral tumor, much above and beyond what you get with checkpoint inhibition alone. And this is a nice example of something that happened in the mouse. What about in patients? This is an example of a patient who was actually referred to me when I was at Penn, who had metastatic melanoma, was enrolled in one of our immunotherapy trials at that time. And you can see what the baseline scan showed in January of 2011. And the patient had multiple mets to the lung, liver, as well as bone, and got an infusion of tremelimumab, which is another CTLA-4 blocking agent, and also CD40 to try to stimulate and provoke an immune response. And unfortunately, the patient progressed within weeks, and the patient had to be taken off study because their performance status declined. And he had tremendous pain to this chest wall lesion here. So was referred for consideration of palliative radiation and was placed on hospice. And so the patient did receive palliative short course radiation, actually to this chest wall met. And then an interesting thing happened. This is in February 2011. The patient was put on hospice, was told to go home, and was told the patient had basically weeks to live at that point. So then in June of that year, the patient called us and said, yeah, I know that you told me that I'll feel a lot better after radiation. My chest wall pain got better, but I've gone from being bedridden to starting to feel better, and I just went for my first run today. And so although you told me that I had just a few weeks and there may be a honeymoon period, we're now in June. Do you think something else is going on? So we had the patient immediately come back, took the patient off of hospice, and we scanned the patient, and lo and behold, the patient was NED at this point. And the patient is still alive today, 6 years plus beyond the initial delivery of that radiation. So what we think happened is this, is that in the setting prior to radiation, this patient's tumor was essentially invisible to the immune system. So checkpoint inhibition, et cetera, had no effect. But then with the short course of radiation, which in this case wasn't truly SBRT, we induced an immunogenic cell death through the release of tumor antigens into the system, and antigen presentation occurred, and so now you had mobilization of tumor-specific T cells. And we had enough CTLA-4 blockade. Tremelimumab has a longer biological half-life than ipilimumab that coupled with this radiation, and so this patient was able to achieve durable immunity. So kind of motivated by that, we started a phase 2 trial when I was at Penn looking at melanoma. And what we found was coupling radiation to IPI. This is an example of a patient who was enrolled on this trial. And it worked pretty well for some patients. It wasn't a big home run, but for some patients, we were able to improve the response to ipilimumab with the addition of hypofractionated radiation. You could see the waterfall plots here showing the response curve. About 20% of patients had a partial response as best response, and then there were some major regressions that were seen, like in the patient that I'd shown before. And all of the radiated tumors were completely well controlled. So this was a step forward, but not a full way forward, in that we found that we had a good augmentation of response to checkpoint inhibition, but it wasn't a grand slam home run. And so the questions are, okay, what else do we need to do to try to move beyond simply coupling radiation with checkpoint inhibition? So what about in lung cancer? Those were data in melanoma. You already heard Dr. Au present data regarding the Pacific trial. We're starting to see greater and greater enthusiasm for the use of immunotherapy in combination with radiation in lung cancer. The Pacific trial is the first trial in stage 3 disease to be positive for a clinical benefit in the last 25 years. So this is a big trial. So this took patients with stage 3 disease, and they were randomized after completion of definitive chemoradiation to either receiving a placebo or receiving a checkpoint inhibitor, durvalumab. And these are the characteristics here. I won't go into it in detail, but the bottom line was you saw a huge PFS benefit with durvalumab. So again, this is the first trial that we've had in over a quarter century that was positive for improving outcome in stage 3 disease. And this is with the addition of immunotherapy with radiation. And there's some criticisms of this trial, and we can go into that later, that maybe the staging wasn't quite accurate, and as a result, since they didn't use mandate PET staging, then maybe some of this benefit that we're seeing is truly due to stage 4 disease. Well, we don't know. How about in stage 4 disease? Does radiation add any value? What we have seen, this is a report from patients who were enrolled on the KEYNOTE-1 study. I'm sorry, there's a formatting error here, but what you should see is that patients who are enrolled on KEYNOTE-1 was a trial of pembrolizumab in stage 4 disease. The patients who enrolled in KEYNOTE-1 who received radiation had a significantly better overall survival as well as progression-free survival compared to patients who did not get radiation. And I'm sorry that the survival curves are not showing up here. And this was published in Lancet Oncology just earlier this year. So again, radiation along with immunotherapy both in stage 3 as well as stage 4 disease seems to be associated with improved outcome. So very quickly, the last minute, I'd like to talk a little bit about where our research is going to try to identify biomarkers. One thing that we are trying to do is figure out a way to track T cells to see if we've generated clonal expansion of a subpopulation of T cells that are tumor specific. And one way to do this is through deep sequencing of the CDR3 region in the T cell receptor coding section, and this is done through deep sequencing, and there's a group that I collaborate with at the Hutch, Hootie Warren, who specializes this and actually developed this technology. And this is an example of a patient with metastatic lung cancer who received radiation to a gluteal met and then subsequently received anti-PD-1 therapy with atezolizumab and had a complete response, complete resolution of all disease. And what was interesting is the patient had significant radiation-induced side effects within the radiation field with just a short course of relatively palliative doses of radiation. And so that brought about the thought that maybe we've generated somewhat of an immune response in this patient. And you could see here, right after radiation, there's this big spike in this T cell subpopulation in the patient's peripheral blood. So we went about looking and sequencing this patient's tumor, and what we found was this patient's tumor had multiple mutations in DNA repair genes. And so what we think happened is that with radiation to this patient's tumor, you had a big neoantigen load because the patient's tumor could not affect DNA repair after radiation, and this led to this big neoantigen load into the system, and then therefore you had a T cell specific immune response that was generated. We have a trial that's ongoing now that's looking to try to take this approach to the next step. We're coupling radiation with PI3 kinase inhibition, which again, PI3 kinase is very important for DNA damage repair after radiation. And we're adding that. The PI3 kinase inhibitor that we're using is nalfinavir, which is a protease inhibitor that my collaborators, my group at Penn, had shown inhibits PI3 kinase and prevents DNA damage repair and functions as a radiosensitizer. And the nice thing is this is an orally FDA-approved drug that's orally administered. So patients receive nalfinavir and nivolumab, and we're now modifying it to allow any PD-1 inhibitor along with radiation. And we will see. This trial is just open, and it's open to patients with metastatic non-small cell lung cancer, melanoma, and renal cell carcinoma. So in conclusion, I think we're kind of in an era where radiation can potentially move beyond simply being a tool to provide local control. that we are beginning to understand the systemic effects of radiation, but there's a lot of work to be done. There are multiple ongoing trials that are aimed at looking at hypofractionated radiation with immune checkpoint inhibition. Not many of them have been published yet, so the data is still very young and being generated. And I think there are parallel efforts that are aimed at favorable alteration of the tumor microenvironment, such as ours, to try to help facilitate durable anti-tumor immunity in both preclinical and prospective models. We need better preclinical models to determine the optimal immunomodulatory strategy for a given patient. It was great to hear the speakers before me talk about potentially patient-derived xenograft models or some of these matrix models of looking at tumor cells in the setting of the microenvironment and trying to see if we can figure out a way to actually reduplicate the tumor microenvironment ex vivo so that we can start trying and optimizing immunomodulatory strategies. So we'll see. We're not there yet, but I think someday we will be. So in conclusion, I'd like to acknowledge this. I've had a whole host of collaborators at the Hutch, at UW-SCCA, including former collaborators also at Penn and at the University of Michigan that have all contributed to the work that I presented here. So I thank you all, and I look forward to answering your questions in the panel discussion afterwards. Thank you.